today's event? Got it. Okay, today's presentation will last for about 1 hour. Please make sure that your microphone is off when our speaker is presenting. And keep your question to the end or type in the chat box. I collect them and ask our speaker at the end. Today, we'll discuss how to do a TCM research. Our presenter, Yiwei Wang, our Vice President of Academic Department of our association, is a Chinese medicine doctor in China, trained with a few master practitioners. And he's finishing his PDOM degree in the US, actually in Texas. He's also a very experienced researcher in TCM with research papers published. So we all know clinical research in TCM is becoming more and more important because it is being accepted by when the TCM is being accepted by the mainstream industry, thanks to hard work of our pioneers and many other practitioners in the US and other countries. So it is our responsibility to show to the public the efficacy and the consistency of TCM treatment. However, many of us do not have enough research knowledge or experience. And some of us don't even know how to start a research project in the US, because it is really difficult to do research in the US. So we are lucky today that Yiwei has an ongoing project that he can share with us about how he designed his research project and the challenges of doing TCM researches in the US. So let's welcome Yiwei Wang. Okay, Yiwei.
Thank you very much. Okay, let me share my screen. Thank you, Dr. Chen. Well, I'm Yiwei Wang from AOMA Graduate School for Integrative Medicine. I'm very happy today to be here to share my undergoing capstone project in my doctoral program with you. So today, I would like to introduce the protocol, every section of the protocol, and how we design it. We're very proud of this project because we are doing it with no funding, not much support, totally by ourselves with very good design. And we hopefully want to do some real research of Chinese medicine to contribute for development of Chinese medicine in America. So the title for the research is Inter-Territorial Reliability of Viscera-Bowel, which is Zang-fu pattern differentiation. So today, I'll go introduce all sections in this Chinese medicine study. I will use about 15 minutes going through the protocol, how we design, and my comments and recommendations. Also with 10 minutes to discuss why Chinese medicine research is important. So before we start, I would like to ask everyone with 2 questions. So what is the most important thing in a TCM study? The second question is, what can a study brings to the field of Chinese medicine? I'll give my answer at the end of this presentation. And I hope everyone can think about it for your answer during this hour. So today's outline, all sections are here. 17 in total, except the abstract. And as you can see, this is actually the protocol, at least in our school. How the protocol looks like. It have every detail in your proposal from start, how you think about it, how you're going to implement, how you're going to prevent, what is a risk. Everything is in here. So this is very comprehensive. Now let's get started from introduction. So our study is actually a diagnostics study. And we know that in the medical field, the medical research have primary, secondary, and have basic research like the cells, animals. We have clinical research like treatment, intervention, the drugs, medical drugs, and epidemiology. That is it's very big data. Also, we have secondary research that is the meta-analysis, retrospective analysis on the evidence, on the papers, and on the data. So this study is just one small piece in the whole field, but we are trying to do some solid work to contribute for the field. So what is inter-rater reliability? Well, this word seems to be very professional. Actually, it's pretty easy. Let's see, this is a picture of the rotation in, let's say this is a morning check of the patients. On the left, this is a physician, chief physician, who's asking questions to all his fellows and other doctors. What is the pattern differentiation for the patient lying here? Well, some doctor may think, the patient seems to be anxious. That could be qi stagnation. Some patient may say, oh, patient have dry mouth. That seems to be fluid deficiency. Some may say, oh, that seems like stagnation. That's true. Some may say the patient looks like very pale on the complexion. That seems to be a blood deficiency. So actually, everyone seems to have their own pattern for the same patient at the same time. So actually, if different Chinese medicine practitioners will give the same diagnosis to the same patients, that is the inter-rater reliability. The inter-rater, that it means between different practitioners or doctors. Reliability is actually the quality of being trustworthy or performing consistently well, which is the degree to which the result of measurement is accurate to be dependent on. Well, in Chinese medicine, things seem to be different with biomedicine, because the pattern differentiation actually is very individualized and also focus on not just the disease, but the holistic system of the patients. So every doctor has their own way of doing pattern differentiation in their life and clinic. Even if they graduate from the same school or graduate from the same mentor or tutor, always say shifu, they may have their own way of pattern differentiation in their later career. So the pattern differentiation, as we know, the core, that is the core of clinic, because it is a very helpful tool to do diagnosis for patient in Chinese medicine. Everyone in Chinese medicine should know and use it in the clinic, unless, well, some student may fall asleep on the class or diagnostic, but hopefully not. Otherwise, everyone should know this and know how it works. So in this part, the pattern differentiation, its importance is beyond words for Chinese medicine practitioners and acupuncturists. So there are some challenges, actually. So this is a table. And from the table, we can see the author and the year of the study conducted in different countries with different diseases and different procedure involved, different number of practitioners and patients, and level of result, which is agreement, reliability. As we can see on the right, the last row, the level of agreement seems to be usually medium or low, except the study conducted in China in 1988, which is about 30 years ago. It's high, others are all low or medium. So this has very controversial, because many scientific researchers of Chinese medicine, they conduct this study in different population, in different country, in different time. And they both found that it seems every doctor have different answer for the same patients. So that is actually a challenge for the pattern differentiation study to be standardized and to be believed or be accepted by biomedicine doctors, because you are not achieving the same result for the same patient. That sounds not good. However, if we see the red, this is a practitioner number and patients number that has been involved in these studies, we can see that most studies only involve about 2 or 5 or 3 or 4 practitioners. And so this shows that these results of medium and low agreement and reliability can only be applied on these 2 people, but not the whole community of practitioners of Chinese medicine. The result, the credibility is limited. It's not very trustworthy. And for patients that we can see, usually there are 50, 30, 40 patients. And the next one is in 2012, that is 84. And also in 2015, that 2000. To be honest, I don't know how to do that, but 2000 is really big data. However, they only have 2 practitioners to do the diagnosis and pattern differentiation for the patient. That sounds not very reliable too. And we can see this green, this disease. So most study only focus on one disease or on the one technique. For example, the Langevin in 2014 conducted study in yin score, yang score, which is actually about, that paper is about the pause, to differentiate yin and yang for the pause. And other study usually concentrated on one disease, random cases, or cardiovascular disease, pre-diabetes. So it seems to be that the spectrum of disease in these studies also limited. So these are the challenges and the questions and problems of existing studies. So we can see that these studies, the result is not good. However, these studies are also somehow flawed and have their limitations, which can be improved by a new study, which is what we want to do. So in this study, the purpose, that is to evaluate reliability, which is the measurement of pattern differentiation, of Viscera-Bowel pattern differentiation technique among 5 diseases. So we are trying to involve more practitioners to discuss 5 diseases in this population and evaluate the reliability between them. So we are trying to improve the study design in existing ones and to give our own design to better that. So the third part, that is the study design. So firstly, this is the flow chart of our study. So firstly, we're going to recruit patients and we are screening with inclusion criteria, exclusion criteria, eligibility, and we're going to contact the patient and practitioners, ask for their consent. After the patient sign informed consent form and complete online survey, we're gonna put them into different groups depending on the disease they have: hypertension, asthma, depression, lower back pain, and chronic gastritis. So we get these 5 diseases are what are most common disease in the Chinese medicine or acupuncture clinic. That is why I want to this disease to be typical you may have in your clinic to reflect the reality of the situation, the clinic. And we're gonna have 20 practitioners to evaluate these patients' information and to do pattern differentiation for them. So for the analysis, we're gonna have practitioners to do pattern differentiation for each group and also for each case. So for each group, we want to say that if every population of one certain disease have a main pattern, and on single cases, we want to say if every doctor will give the same answer on the one single patient. That is a reliability. And then finally, we're gonna collect all the data from the patient, from the doctors, from practitioners, and to do the reliability analysis based on that data. So participation. So this part is about who we will do the study with, that is selection of the participants. In this study, we're going to involve 2 cohorts, which means 2 groups. The group 1, that is 50 cases of patients with asthma, depression, chronic gastritis, including GERD, gastroesophageal reflux disease, hypertension, and lower back. Each group had 10 patients. And in cohort 2, that is for practitioners, we're going to have 10 practitioners from American training school and 10 practitioners from Chinese training school, because we notice that in the existing studies, the results indicate that practitioners with different education background may give greatly different results and pen differentiation results for the patients. So we want to test it in our study too. So as we have selected the participants, we want to know how we're going to recruit them, how we're going to find them. Firstly, we have flyers. This is what we have designed, and we can put this in the clinic, and also the digital version will be posted in the media like Facebook, like groups like WeChat, and to spread them, distribute them, to let more people know that we are doing a study, are interested in it, and letting people know what is about this study, our inclusion criteria and benefit and contact information. So after patient like scanning the QR code here or contact me, we will have the phone script. So this is just one slide, but we actually have a whole document about the script for calling and email. So this is very important when we are applying for the IRB, because, for example, if we contact with a patient, we do not want to just tell them, hey, what we are doing this study, but we need to have a logic. What are we going to tell them first? What is the logic of the study? What is about? What is the risk? So we should have steps written down and prepared before we implement the study and protocol. So for us, this is the version. The red, that means the patient is not available, which is negative. And the green ones, patients say yes or a positive answer. And by going through every step, it will be very easy and will be centralized information to give them to people. So the inclusion, which is the eligibility, is very important. It's about what detailed information and what detailed requirements for participating in this study. So for the cohort 1, that is the patient, we set the age to 18 to 80 years old, because 18 to 80 is adults, and this is usually the study can do. However, in other studies, it may mention or just include patient with certain age range, like 40 to 41 or middle age or something. This one, 18 to 80, seems to be more acceptable for most studies. And under 18, that is kids and teenagers, that requires far more details and requirements and information to IRB, stating that why we want to do study on kids, because we must protect kids and teenagers. We should not bring any risk to them, except the benefit is larger than the negative results. So the B, the cohort 1 eligible B, that is biomedicine diagnosis of hypertension, asthma, depression, lower back pain, or chronic gastritis by a physician or other health provider. So it may sound weird that we using the biomedicine diagnosis for a Chinese medicine diagnostic study. However, it is important in current studies and research fields, because if we want to test the Chinese medicine diagnosis results, we must need a standard biomedicine diagnosis to have a controlled and definition on this population diseases. Otherwise, if the patient say, hey, I have hypertension, I think a Chinese medicine doctor tell me I have hypertension, should I join us? If you recruit them, there might be a result that every patient actually, or some patients may actually do not have hypertension, but just have similar symptoms. So that would be a very great problem and flaw of a good study design. So controlled definition of disease is important. Next term, that is volunteer to participants. It is also important. We cannot force anyone to take part in the study that is not that is not good at all. And that is illegal, I think. And we should tell patients, inform them the risk, benefits, the procedure, the time, what they're going to do, what information we're going to collect, and ask for their consent. After they sign in the informed consent forms, things done. That's good. They're good to go. They're good to join us. Sorry. So for the cohort 2, in this study, for the practitioners, also aged between 18 to 80 years old, and also have an education background in Chinese medicine, Oriental medicine, or acupuncture in either Chinese school or American school. This is the criteria we set to respond to the earlier cohorts and the aim of the study, because we want to evaluate to test if China-trained practitioners and American-trained practitioners, if they will give different answer, or how different the answer will be in pattern differentiation. And also, we need them to be licensed to practice Chinese medicine, Oriental medicine, and acupuncture, no matter in any state, just licensed. Because if if a doctor or someone is not licensed, which means he's not really in clinic, he's not using pattern differentiation in real life. That is not what we want to recruit. We want to test in real scenario. And also volunteer with to sign the informed consent forms. So exclusion. Actually, I know many experts here tonight, but also some students may hear this. So exclusion does not mean all things except inclusion, but some particular thing you want to exclude and avoid in your study. So in this study, we think the exclusion for cohort 1, the patients, is first, a patient who suffer from severe disease or symptoms, lung, heart, kidney, liver, cancer, cerebral injury, etc. We will not include them. We will not recruit them because it is actually to protect them. They need to treat the disease instead of doing studies. And also mental disturbed patients with slurred speech or difficulty in describing themselves, in Parkinson's disease, Alzheimer's, psychological diseases. This is because we need participants to have clear mind, know what they are speaking and what they are doing. Because we need their accurate information from patients who want them to give us their, want to tell us the disease, the course, how long they have been having this disease, what symptoms they have. That is important to be accurate. And also the patients, if they are actively participating in other clinical trials, we will not recruit them because if they are participating in other trials, it may influence their result and their health situation, and the health situation may change, and there could be some potential conflict between other trials. And also other conditions may apply, or may limit the patient's ability to participate in the study. That is broad, just put there at the backup plan if any other situation we cannot imagine now. So for the cohort 2, the exclusion is like this. Firstly, not in active practice for over 5 years. So we set the time for 5 years if they're not active, if they are inactive, because we think if the practitioner is not in clinic doing treatment for patients or using pattern differentiation for 5 years, he may forget a lot of things. And it's like a tool. If you do not use it, you'll forget how to use it in the future. Secondly, that is also similar to the cohort 1 exclusion, that practitioners suffer from severe disease or have difficulty describing and stating their information. Next, that is a withdrawal. So as we have stated to IRB that what kind of patient want to recruit, we should tell IRB that how patient going to opt out from the study. So there are two situations usually. One is withdrawal decided by participants. That is the participants, both in this study, both patients and practitioners, they can leave, they can withdraw for any reason at any time. It is their right. So this is actually also a protection to participants. If they have any issue, if they have any discomfort or any risk factors, they have rights to withdraw on their willing. We cannot like put them in here, always calling them to join us, to come back. No, we cannot do that. It is not applicable in clinical research. We should protect their rights. And also there is another situation that withdrawal decided by researchers. So especially us, as researchers, we also have the right, and we need to monitor the process of the study from start to end. So if some participants, let's say, when they are doing the research, when they are filling the questionnaire, some may choosing all A, choosing all B or C or D, and like if they are not just trying to mess up the things, we should politely ask them to withdraw because they are not really doing the study. They're just messed up things. It is real, but it does exist, such situation. So in the fifth section, that is the research strategy. So this is more about implementation. Your plan, our plan actually in here, how we gonna do this study. And so here are 3 attachments, 3, 4, 5. That is the questionnaire for 3 different groups. So the first one, that is a patient history questionnaire. It's actually a history taking. The questionnaire A is designed to follow the routine Chinese medicine diagnosis process, beginning with a chief complaint and diagnosis they have gotten, and then identify the critical components of the 10 questions. That is, I think that is very basic. As we know, that is basic Chinese medicine history taking of the 10 questions. So in this study, we are trying to use some standardized terms from the CCMQ, the Constitution in Chinese Medicine questionnaires. It is not designed for a diagnostic. However, it is a very good tool to collect information from the patient, and it has been designed and tested in clinic for decades. They are good questions and they are very comprehensive. So we use it as a guideline when designing questions for patient history taking. So questionnaire B is to collect demographic information from practitioners like educational backgrounds, clinical practice preference, and pattern differentiation results for 5 groups. And the last questionnaire C, that is for single case pattern differentiation results. So this is how the very first questionnaire looks like: the age, the weight, height, what diagnosis they have been given, the symptoms they have. So in this test, the patient will be asked, the patient and practitioners will be asked to fill this small text or with single answer or multiple answers. So after collecting all the data from the patients, we're going to do the data formatting. So the raw data, it need to be processed and turn into some turn into some formats so we can send them clean and clear to the practitioner for them to read and do the pattern differentiation. So this is an example. It's not real statistics. For example, the patient, if they have any symptoms like nausea, vomiting, that is 0%, this for group, and in early morning headaches, that is 67%, that is pretty high. So as a result, the practitioner was seeing this chart and say, oh, okay, in this group, more people have early morning headaches and no people have fatigue, nausea, or something, these symptoms. So they can do the pattern differentiation based on this information. And also there's another example for the terms in questionnaire A. The patient results. So in the lower part, we can see no, rare, sometime, frequency, always with different colors. So it will be easier for a practitioner to see what is going on in this group. And this is also for the case. And if the patient chooses real, little, or sometimes, and frequently, will give them different colors. So the practitioner will see this chart and say, oh, okay, this patient have real allergies and real cough or heavy breathing due to seasonal change or something, and sometimes have other symptoms. So it will be easier for them to read. The reason why we are not putting this information into a, let's say, traditional history taking like a form we use in clinic, just give patients some, give practitioners some information, let them do the pattern differentiation based on like a NCCN board exam. We are not doing that because we want to, as mentioned, reflect a real scenario in clinic. All doctors listen to patients and ask patient questions and get the answer and process with their brain. They are not given this information just like a small paragraph or text, like an exam or test. They need to read and they need to ask this question and get pieces of information together in the brain and have a pattern for this patient. So that is what we want to reflect in this study, that giving pieces of information to practitioners, not just like a test or board exam. I know Dr. Chen tell me they have enough tests in the school already. They don't want to have tests and exams anymore. It won't be like that. Actually, it will be harder than tests because you need to process this information by yourself. So in next section, that is the pattern differentiation and outcomes. So let's say we have all the information from the patients and from the practitioners. Okay, what are we going to do? So next step, what are we going to do is to do the randomization in the single case and blinding. These two technical methods are not very common in the diagnostic study, especially for Chinese medicine. Because Chinese medicine cannot do the blinding to everyone. However, in this study, we do try to use the randomization using the random number. So this is called the simple randomization. We use Excel to generate some random number for each case. And you can see here, this is total random from 0 to 1. It's not input by me. It's just generated by Excel, the software. And we give the number of each case, and then we reorder these random numbers from largest to the smallest. And then we can know which one is largest. It's 9, 1, and 4. Okay, these three are the lucky cases to be used in our study for single case and send them to the practitioner. So this randomization is important because we do not want to use the dice. Okay, let's roll the dice. Okay, we get 1, we get 3, we get 6. One of the things that they only have 6 number, and another thing is that this dice is not a standardized way for methodology in research. Well, there is a joke that if you roll the dice and count the numbers, you should actually list the Jesus Christ up in your paper when you publish it, because he helps you to do the randomization process, right? It's just a joke. But with the simple methodology with Excel random number generation, we can do the simple randomization for study to have a more objective results. It's like I'm a researcher, but I am not picking cases for practitioners. I'm not doing that for them. This is to avoid my personal preference or bias. So blinding is also important, but we cannot really do blinding. It's not making them blind. It's actually hiding some information from each practitioner, which is a rater who's going to give the result of pattern differentiation. So we recommend them to, actually we ask them, the practitioners, not consultant or discuss with other practitioners on the content related to this study. So actually this study will use the online system and distribute the patient information, patient medical history de-identified to each and every practitioner to do pattern differentiation online, which means we're not asking all the practitioners into the one room and give them paper and let them do this pattern differentiation. It's not like that. They may just do a study at home, so it is actually there's just by them alone. It is also a way for blinding in this study. The data storage. Okay, in this section, we should present that how we store this data. The data is sensitive. Some data is identifiable and like name, age, which must comply to the HIPAA. So in this study, we use a password-protected, encrypted REDCap database. So this is a research tool that we can do the questionnaire online and collect information and store the data. Data will only be accessible to the research team. So there's also a way that we can protect the data of the patients. Next section, that is a statistical analysis plan. So in this section, we're gonna tell the IRB and people who read the protocol that how we're gonna process the data. There are two main categories, that is descriptive statistic and statistic analysis. For descriptive, that is just like we're just counting, okay, how many patients answer yes to this question, how many patients answer yes to that question. That is the simple one, we just count. But for statistical analysis, there's more complicated method needed for this study, that is called FLES-CAPA. So CAPA is a methodology, a statistical methodology for the reliability studies, initially designed for biomedicine studies to see if every doctor had the same answer for one patient or diagnosis. So we use it for Chinese medicine study. It is applicable. In this table down here, down here, it's the example. So rater we have 10, let's say 1, 2, 3, 4, 5, 10, and every rater will give a pattern differential result for each group. Yes. And we're going to compare and put this data into the SPUS, that is a software to do the analysis. And the system will give our result. It's a CAPA value. So this value will show us the level of agreement. If level is 0.2, let's say that is slight agreement, which means the reliability is very low. And if it is 0.81 or 0.99, that is almost perfect, which means everyone have the same answer. So everyone have the very perfect agreement. That is what we want to have, actually, to be a researcher. So after analysis plan, we're gonna give the study schedule. So in this section, this is a table, for example, of our study. We're gonna list everything we're gonna do in this study and the anticipated time to be done. Actually, it's always a good thing to track your study progress because there's a lot of accidents and incidents. As the changes always occur, no matter how perfect the plan is, we can know if we are back of the plan or we are forward of the plan to decide what we are going to do, if we need to do any change or doing the modification. So preparation for materials. Usually for studies, especially clinic studies, with intervention for say like herbs, formulas, acupuncture treatments, the RB and protocol requires you to give the detailed information. What kind of needle you're going to use? What kind of moxa? What kind of herb? The batch number? Which company give you this herb? And when it is manufactured, and if it is approved by FDA in America, and all this information will be required. That is necessary to make sure that we are using good stuff and for the patients. We must protect all participants, their safety, anything. So all medicine herb treatment techniques should be detailed. However, in our study, we do not have any intervention or treatment. We're just collecting information. So no medicinal substance or device. The human biology sample and biohazard containment. So this is originally designed. This session is originally designed for the clinical research involved intervention. So if the patients, for say like, if the researcher gonna collect the blood sample of the patient to do some blood test, or they're gonna store this example of urine or biopsy samples or the skin or the hair or something, how they're gonna store and how they're gonna process after the study is over. This is also very important for a study involved intervention. But in this study, no, it's a good thing we do not have such sample and such requirement. potential problems and alternative approaches. So in this section, it's about you, as a researcher, you need to consider what could happen in the study. And if the problem occurs, what are we going to do? Usually we just list all the potential problems and give our possible solution. For this study, actually, we're just recruiting patients. So recruiting is actually a challenge. As you know, recruiting patients for studies is very hard. The patient absolutely not want to be your white mouse or white mice, white rat. So it is possible that we cannot recruit patient on time, but we still need to try our best. If it can not meet the standard and the 10 patients in each group, we can lower our anticipation and just do the data analysis with this like 5 or 6 patients as much as we have. But if your study, for example, if a study involves herb intervention, you need to prepare for plan B. Yeah. Okay, for next section, that is the risks. Also, risks from potential problems is that the things it may occur in your study and could be an obstacle or problems, but risk that is for the negative results usually. For example, in this study, the risk including breach of privacy, the information of the patients, adverse events, and discomfort experience. Some patient or practitioner, when they are doing the questionnaire, they could have some negative feeling or trigger their trauma or something. It is possible. So, and that is a risk we can anticipate, and we should tell the patients in the phone and when in the communication before we ask them and recruit them. And also adverse events, that is a very broad topic, but in this study, it is mainly about the patient get pissed off or angry with some question, or some participants also feel bad about it. That is adverse events. And breach of privacy, that's also, even if no matter how perfect we planned, there is still maybe 0.0001 possibility the information leaked. And we should tell the patient and claim the risk before recruiting all participants, letting them know in the informed consent communication or discussion. So confidentiality. So it seems to be mentioned in data already, the data storage part, but actually they still need to be clear in a single section because it matters a lot. The confidentiality, that is our way to prevent the risk of leaking of data. Firstly, in this study, we use password protect encrypted RedCap database. It's a very good tool. Second, we comply to the HIPAA privacy rule and safety harbor and expert determination methods. Thirdly, we only give access to data to people only with permission of principal or co-principal investigators. And all clinical data we collected in this study will be shared only by encrypted, de-identified Excel spreadsheets or Excel forms, or in RedCap, because this is to remove all identifiers, the name, age, weight, things like that, according to HIPAA, and to make sure that even if our clinical data has been leaked by someone or some organization like hackers, I don't think they're interested in our study, but it could possibly, even if they get the data, they will not track back who involved, who participated in this study. It's also a very good protection for our participants. And also RB members, they have the access to data because they will do inspection on us from time to time. Okay, now next section is compensation. Well, for this study, we have no compensation. Well, because we do not have any funding. And for Chinese medicine, it's really hard to get funding of research in America for NIH or something. Especially for us, we are just doctoral students, want to do some real good study, but we do not have money. What we can do? Well, an alternative is to give participant a free treatment. If you are licensed, for example, you can give the patient, say, if you can help us collect information, we can give you a free treatment for pain or something. That is applicable. But in this study, it is not applicable in our clinic, so we can only say that no compensation. Or sometimes if we have funding, if other people have fundings, if they sponsor us, we can give people like $10, $20, or give them a gift card. This is very common in the questionnaire from the commercials. It can be applied here too. So if we have money, let's say, that will be the cost and budget. Well, fortunately and unfortunately, we have no money in for this study. So the only cost will be printing the flyers and put them in the clinic. And there will be no charge, no fee for patients or practitioners involved in this study. Next part is consent. Wow, this is a very big topic. It involves informed consent discussion and informed consent form. So discussion is something you need to talk to your patient on the phone or in person. And in this study, we will talk from phone or email and to tell them what is the risk, what is the benefits. If there's any compensation, well, unfortunately, no. And what we're going to do, what information we're going to collect. We are required by IRB to detail every information to the patient before they consent to join this study, to make sure they know their rights to withdraw and their rights in participating. And usually this work will be done by me, which is a co-principal investigator, or principal, which is my mentor, or other staff in our team. And after patient knowing all their rights, after we giving them all information and answer all the questions they have, we will ask them to help us sign the informed consent form. So absolutely every clinic should have this, but in study, the design will be different. It is more about the process and other details mentioned, but they are all available. They should be available in this protocol. So final part of that is reference. So for reference, I have some, I usually will use the tools, the software, Zotero, EndNote, etc. It's very helpful because it is really not recommended to do reference and writing down the number one by one by hand. That is not applicable. If you need to change some paragraph or change the reference, it will be very hard. But with the software, you just need to click. And also, it's very important to read and cite crucial papers in the field because, well, submitting the protocol to IRB, some experts and members will check your reference to see if you have read and cited the important papers in this field. If you're not, it's possible that you do not even read this paper and barely know good information about this study, and your study design will be not very reliable. And also copy does not equal to cite. I see some colleagues will copy the sentence from a paper and give a citation to that, and that's it. It is not good. It's some sort of plagiarism. Because if you are citing, you should citing their point of view. You're not citing their exact words. You're using their information to support your opinion, but you should not just copy their sentence and words and phrases. So this is a study. This is my protocol. It's very simple going through because I want to show anyone who is interested in Chinese med study without having any funding and do not know what to do. This is more like a guideline to show you what a real protocol looks like and what section should be about. But to be honest, we face a lot of difficulties in America with Chinese medicine studies, including regulatory barriers and approval delays. Well, I have spent 6 months on IRB and on the protocol, and this is a nice version, 9.2 version of the protocol and proposal. I have to modify and revise again and again. Also, site selection recruitment, as I mentioned before, recruitment of patients is very hard, especially when there is no compensation. And your study, if it is involved in the intervention, they will think, oh, am I your white mice or white rat? I don't want to be your experiment subject. That is very common, and we should go with that. And no funding, well, as mentioned, it's very hard to get funding from NIH or the public for a small research like this. And which means we cannot do a lot of things. As you can see, this study is my study is far from perfect. If you look at the literature, you may find some study, they have money so they can recruit all the practitioners in the same room, face the same patient at the same time. That is more accurate, and they can involve the town, can involve the pause. However, we do not have money to afford that, afford the ticket, the time, that of the practitioners, all the patients. So we can only do that online with information. And we also lack professional clinical research staff in our school. We only have a few professors have experience and background of research in Chinese medicine. And also there's anxiety and depression. That is for the researchers. For example, that is me. And there's a lot of difficulty you need to confront with by your own. Even if you have help, it's still very frustrating because you need to change, modify, revise again and again until it is approved by IRB. So actually, this slides answer the first question I've had in the very beginning. That is, I think the most important thing in TCM study is design. A good design, for example, our design, I think is pretty good because it requires for no funding, but we can do some real things. And for the research, we're not just doing some literature review. Well, one thing I noticed that many doctoral students prefer to do literature review. It's not a bad thing. I'm not rejecting that, but I think literature review is the very first step of every study. But if you want to contribute to the field and do some real study to accumulating some real evidence for Chinese medicine, we still need some clinical studies or basic study or epidemiologies, not just do some retrospective literature review. So next I want to talk about the Chinese medicine, why we need good clinical study of Chinese medicine in America. Well, to be honest, I've been doing study for 3 years in my master's program, and here this is my 3rd year of research and study and clinic learning. I think they are actually related. Research and treatment are related, but they are two totally different areas. It requires for different skills, thinking, thoughts, methodologies. There are great difference between treatment and research. To be a good practitioner, you just use your knowledge to relieve pain, improve symptoms, you're good. However, research propose more in-depth questions. What is working? Why it works? Why it is not works? Under what circumstance it is effective or not? So these are very basic questions and can help Chinese medicine techniques to be proved and accepted by the mainstream and also more people, more patients. And personally, I would say learning from textbook or mentor like in school is passive learning. You're just accepting knowledge and point of views from others. But doing research is active learning. So as a doctoral student, I think this is very good for me to read hundreds of papers, both in Mandarin and in English, from different countries, and read the guidelines, read other people's proposal, learning how other people do these studies and how they think about the Chinese medicine diagnostic and pattern differentiation. It is a very good time for me to learn from people I would never met, actually. The paper, the books, I would never met the author, but in this chance, I can learn their thoughts and help me to form my own thinking and thought about Chinese medicine development and research. And also it will be very helpful for my clinic because I can know how to explain to patients what is pattern differentiation, what is qi, why we say you have qi stagnation, why we say I give you the diagnosis of the blood qi deficiency or something. Another thing that for communication, well, I think every practitioner needs to know how every conclusion of Western medicine comes about so that you can talk to biomedicine doctors by not just contacting them saying, hey, I'm an acupuncture, I'm doing this thing, I'm treating this disease. But if you know how Western medicine do these studies and achieve these conclusions and use these conclusions in clinic, you can actually tell them more details. Like we have the pattern differentiation, when we give the patient, we may explain to the biomedicine doctors how we gonna diagnose patients, how we do the treatment for them accordingly, and why we use acupuncture and what evidence has been proved in research about acupuncture in which disease, and I'm very good at it. I think it is very important to have a common language. The common language is not just the biomedicine terminologies, but the logic, how they use this terminologies, and how they achieve all these conclusions that they are using in their clinic. I know how you do that. I know why you do that, and I'm going to explain how I'm going to do that and how I'm going to bring benefits to the patients. Yeah. And if we can do the research, and I think it's also a proof to tell people, your patients and other biomedicine practitioners that we are not just responsible for treatment, but we can also be responsible for hard, detailed scientific study based on their criteria, your biomedicine criteria and framework. We can do that, and we prove something solid. This is a good way, I think it's a good way to gain trust from the doctors and practitioners. Another thing is that, like Ms. Marilyn Allen mentioned earlier in another presentation, that there are a bunch of good studies in RCT in China conducted with very good professional teams, epidemiologists, statisticians, doctors, but most insurance companies will not trust these results because they are not conducted in the United States. So that is why if we can do some study in America and giving some proofs, it will be very helpful for the policymakers and companies, insurance companies, consider, hey, this is good. This is a good study result, and we can consider bringing them into our policy or something. So this is actually the second question. My answer to the second question, in the very beginning, that the communication, the research can bring good thing to person, to a researcher, but also bring very good result for the community of acupuncture in America. So workshop, the section, so today we talk about the sections in real Chinese medicine study protocol with AOMA version in our school. Different schools may have their own protocols, but basically they're the same and similar. And we talk about each section is about and tips to make it to better, my comments and my suggestions. And also we talk about why we need more good Chinese medicine research and researchers. Well, in China, there's a old saying that there's no way to reach 1,000-mile travel without each and single small steps. And there's no river or seas can be formed without every single drop of water. So I know this study is simple. This study is not very not that fancy, but a lot of people coming in, which large sample size. But I want to show the students and practitioners who may be interested in studying, hey, we can do some small study like this. We do not need funding. We can do some real work, and we can gain some solid information and data from clinic, and we can analyze them and give our conclusion to the field, to the community. So doing research is hard, doing studies is frustrating, but doing studies is the only way we can explore the unknown field of the medicine, both biomedicine and Chinese medicine. We can tell the truth from false and strive for greater living space and market for Chinese medicine and acupuncture. Okay, this is almost the end. So for this study, I am also going to do an advertisement for myself. We are recruiting because, as I mentioned, it's very hard. Nobody wants to join us because they are not interested. We cannot pay people. We do not have money to do that or fund to do that. So we need more practitioners that are willing to sacrifice their time, energy to be with us. And also we need more patients. If you have any family member with these 5 diseases, please contact me. And the students and also practitioners or anyone who are willing to join and learn something about Chinese medicine studies, I'm very happy to invite you to join our team. Well, I have to say we have no money to pay you, but I can teach you by showing you how to use these professional tools, the SPAS, the methodology, well, the analysis method, how the randomization, blinding, these things. We can use software. I can teach you with that, and you can see. Well, for students, you can see how stressful and anxious when I do this research, and you may consider seriously before you go into a doctoral program. And yeah, and also if you really join us and do great contribution, we absolutely will put your name in the paper if we publish the scientific paper later. I think we're going to do. This is my email, phone, and WeChat. Please contact me if you have any thoughts, comments, or willing to join us. Thank you very much. Okay, this slide is just some my tips for personal tip for researchers. For starters, actually, because I'm here from Rocky. I know there are a lot of difficulties and people may be interested in, but they do not know how to do. So if you are going to do your own research, you can take these tips. Okay, thank you very much. So this is the end of presentation. Thank you for your time and being here. I know this is a very cold topic and not much people want to involve in your research. It's not paying back or something. You don't get paid, and you had to sacrifice a lot of time and energy in that. But hopefully we have more people to do some real work. Thank you very much.
All right, thank you, Yiwei. Wonderful presentation. And thank you for your offer to help newcomers. Now, let's do Q&A. I have one question from the chat box, then I'm open to the floor. The question is, I'm a new student, interested in research. I wonder what are the sources of funding for Oriental medicine research? I think you already gave the answer. But I think we might have some other answers from experts in the audience.
Yes, very interesting. Very good question. Because I mentioned we can barely get any funding. If you have a mentor and you're in a program that they do have funding already, that would be easier. Because if they have funding, usually the funding comes from government. That is in America, it's NIH, National Institutes of Health. They will give funds to studies and they will sponsor the studies. But they do have their requirements, like some may require to have open data, open access. Some require you how you need to report how you're going to spend this money, the cost and budget, the section. And another way is sponsored by the company and private people, companies, something like that, like the pharmacology companies. They will pay a huge amount of money for their products if they need to do research in Chinese medicine. Another source is actually from the public. There are some, let me see, there is a word for that. Crowdfunding, yes, crowdfunding. Some websites allow the practitioners and medical providers or researchers to collect money from the public. If they can show people, hey, this is a good study. If you're interested, you can sponsor us with $1, $5, $10. They usually will set a goal and to getting funds from the public, anyone. Yeah. Or you can pay your own money. I mean, if you're rich.
Great. Any questions from the audience? I see a comments from Dr. Jane, who typed in the chat box. Thank you, Dr. Jane. And Dr. Lee. And Marilyn. And thank you, Evelyn, for your information.
So I know this is a very cool topic and not much people interested in it, but I'm still very confident that there will be more and more people want to involve in the research. And the good thing in America is that we have many people learning Chinese medicine from different professions and backgrounds. So that is more possibility to integrate Chinese medicine with other professions. Like the AI, the chat GPT things is really cool. Yeah.
Yeah, Dr. Tian, would you like to offer some comments?
All right. Thank you so much. Thank you for Yiwei and gave us a nice talk. Because most of us are clinician, mainly practice acupuncture, Chinese herbal medicine in clinic. We treat most of the patient. Research is a completely different kind of subject. A lot of people, just like Yiwei just said, not too many people interested in that. But actually research is a very important topic we have to involve, especially for our doctor program students or who already hold the doctor program. We really count on you to do a lot of research on that. The reason is that because when you see a patient, when you see 10 patients, see 100 patients, this all is just like a, may think about special cases. But when you try to convince somebody, they say, give me some article or research project to show me based on the very strict controlling to prove is really effective. So because all the insurance company and other scientific institute and also the medical doctors, they really challenge us to say, we don't want to say you treat one patient is better, another patient is better, but we really want to see something. So this kind of research is really to prove Chinese medicine is effective. So that's why we really encourage you to gain more interest, get more participate for the research in acupuncture. Also, NIH each year give out a lot of funding and to do acupuncture research. But sadly, our clinician rarely has people showed interest and participate. Mostly like a medical school, some acupuncture researcher, they do something. But when they publish some papers, some they show positive result, which we're so happy. And also some papers showed negative research. When we see those things, we're so angry, upset about that. So how we can change that? We always criticize your research design is not good, and the point you select is not good, the stimulation method is not good, and so on. So that's why we need to involve. We become the leadership for the acupuncture research. So that means we can prove acupuncturist work and then can give them more evidence. So that's what I want to say first. Based on Yiwei's talk, I get some kind of comments. Number one, in order to get a group of patients into the research group, first one, you have to make the standard for diagnostic standard, because only you have this standard set up clearly, you can gather all the group people in that group to do the research, to perform the research. So that's why to set up a standard is so important. I think Maryland also always suggests us keep a standard, high standard. So that's number one important, standard for diagnosis. That means the people can get involved and also to kick out, also cause some withdrawal or something. So that's number one, standardization. Number two, about the diagnosis. We know Western medicine, they are good at diagnosis. They performed a lot of kind of skills, machines also make the diagnosis very clear. But the Chinese medicine, this part we think is kind of weak. The reason is that you can look at our textbook. Mostly our diagnosis like a diagnosis based on the symptoms, such as people like a stomach ache, such as people lumbago, such as people have a headache. So this one is pretty much all the symptoms diagnosis. So that's the problem, because we are not only treat the symptoms, we really need to treat the disease, because the disease really give us general idea about this disease and also the prognosis. For example, if the people who has a stomach ache, they could be just by eat something wrong, temporarily got a spasm. And after a while, maybe 20 minutes, 30 minutes, the symptoms can go away. But some people who has a gastritis, and especially the chronic superficial chronic gastritis, those people can last months, 1 month to 3 months, still treatable. But the people who has a stomach cancer also can show just a stomach ache. If you just use the symptoms as a diagnosis of disease, so that's a treatment and the prognosis will be problem. So that's why when we make a diagnosis, and not only to make the symptoms diagnosis and also make disease diagnosis. This also important is because, so for example, it's about quite a few years ago, Australia researcher, they try to use acupuncture to evaluate acupuncture how the knee pain. So knee pain is only a symptom for the knee, but there's so many reasons can cause the knee pain. So definitely different reason cause knee pain. The treatment result will be way different. So that's why we can use Western medicine to classify and narrow down what kind of problem we're really treating for. That's also is good for the efficacy evaluation assessment, because the symptoms relief does not equal to the disease cured or improving. Number 3, when we have the diagnosis, I talk about the clinical stuff, okay? It's a dynamic. Because when we get a diagnosis, we say like a chi stagnation, blood stagnation, or damp heat, when we diagnose certain things with the differentiation of the pattern, I think the Yiwei mentioned many things, the differentiation. So for some disease, like a chronic disease, they could keep in one pattern of the differentiation. That's okay. From the beginning to end, you can treat people such as like a spleen qi deficiency, blood stagnation. You can treat them for 3 months, 10 months, no change. But for certain kind of disease, they have the stages. So that means when you treat them, could not use one diagnosis, treat them from the beginning to the end, such as the COVID. Okay, the location could be in the lung, could be in the stomach, like ulcerative colitis. At the beginning could be damp heat, then change to spleen qi deficiency, then change to the blood status. So that means when you get diagnosis, you have to make sure that's a dynamic. So that's why our Chinese medicine have like a, say, to treat the disease by different way, because even the differentiation same. So same disease, different disease we can treat the same way. So that's what we say. That's the number 3 I want to say. Number 4, for the real clinic and the research is different. Research we need again, after we get diagnosis, the treatment, such as the formula selection, such as the point you use, all had to be standardized. Maybe we could not use too many points, not too much modification. So that means a certain group of herbs, certain groups acupuncture point, we could not change. But so how we select those points is based on the clinician's experience. Not only the textbook could be give you a general idea, but a different kind of senior practitioner, they all have the personal experience, such as this group people like use this common point, sometimes use like a local point, something like distal point, 5-shoe point. It's different. So we try to use everybody experience, try to design the clinical trial to the best way. So that's why the different doctors, they look at one thing from a different kind of angle. So even get the same diagnosis or different diagnosis. So the treatment principle, the formula selected, the point selected could be different, but they still could get the same good result. So that's the characteristic of the Chinese medicine. It's a little different from the Western medicine. The last one I want to say, little thing about the translation. Yiwei gave us the topic today, and say Viscera, right? And a Bowel differentiation. So I want to know is you put a Zang-fu, put a Bowel in there, is accurate or not? So I wanted to think about you put the Bowel in indication we want to use the word for fu. Visceral, that's a Zang, can be including fu also, but I don't know it's appropriate to put a Bowel over there. Whoever born here or speak English perfect, so you may give us some suggestion. Is Dr. Jin there? Do you have a different opinion about for the translation for the topic today? Regarding the translation of the Zang-fu. That's the little comment I want to say. Thank you so much. It's an excellent speech.
Thank you very much.
Thank you, Dr. Tian. Excellent comments. Is Dr. Jing here? Okay, guess not. If there's no more question, I guess we can wrap up today's meeting. We thank you all for your participation. And today, we wrap up all the events for February. So please remember to check your email for events in March. Thank you and have a good evening.
Thank you, Dr. Chen, also. Your hosts are wonderful. Thank you. Thank you for everybody.
Thank you, everyone. Have a good night.
Good night.
Thanks.
Bye-bye.
Bye-bye.